Hello, my name is Tiara Evans. I'm a second year medical student here on the McCann Mercer University campus. And today I'll be introducing Dr. Keisha Callins. Dr. Keisha Renee Callins is a physician and public health professional. She is an obstetrician gynecologist with Community Healthcare Systems Incorporated and is committed to providing healthcare services, especially in Central Georgia. Dr. Callins also serves as a professor in the Department of Community Medicine at Mercer University School of Medicine. She earned her Bachelor's of Arts degree in biology from the University of Virginia. Master's in Public Health degree from the University of Alabama at Birmingham School of Public Health, Doctor of Medicine degree from Morehouse School of Medicine, and graduate medical training at Morehouse School of Medicine OB/GYN residency program, where she served as chief president. She is actively involved in pipeline mentorship, translational research, legislative advocacy, and community engagement. Her personal mission statement is, "You may not be able to change the world, but you can change the world of everyone with whom you interact." Please help me in welcoming Dr. Keisha Callins.
Good afternoon, everyone. Good afternoon. Oh, we can do better than that. I know you ate, and there's postprandial alkalosis. However, let's try again. Good afternoon, everyone. Good afternoon. Okay, that is better. Thank you so much. Thank you, Tiara, for that wonderful introduction, and it's such an honor to be able to speak with you today. Thank you to the Rural Innovation team, their wonderful staff, for inviting me to come and address you today. So today really is going to be kind of more like a conversation. I don't want to talk at you. I kind of want to talk with you as we think about ways to improve our maternal health outcomes. And so I have a couple of interesting slides and stories that we'll share along the way. And I'm hoping that at the end we'll have enough time for some questions and some conversation. And even after we're done today, you will have access to our slides, and we are happy to communicate with you. Before I start, I want to ask some very special people in the room to stand up. And towards the rear of the room, we have a bunch of medical students. The future of medicine is here. Would you stand, all of our medical students? Do we have any residents? Okay. Perfect. I really wanted to just give a special shout out because this is the future of medicine. And so you know that everyone goes into medical school wanting to do really well, wanting to help people, and then sometimes things get a little bit interesting along the way. So before you leave today, I'm going to ask everyone else to reach out to one of our medical students, their white coats, and then there are three over here, and just make sure you tap them and remind them to be nice to their patients, okay? And to listen. So thank you for that. She mentioned and to listen. And so I really wanted to set the stage for the conversation because we've heard a lot of really good information today about maternal health care outcomes. We know we have a problem, correct? We know we're not doing that great. We know that there are a lot of things that we can do to improve that care. We've heard a lot of good suggestions regarding that today. The presentation regarding fertility is very important, and I'm really happy that that was featured today because we think of the happy things that happen with pregnancy, but thinking about the difficulties sometimes in achieving that goal, and then also even pregnancy loss, the not so pretty side of things where you think things are going well and 6 weeks in or 6 months in, things don't go well. How do we really address all of those things? And so the purpose of this presentation really is just to remind all of us about the important elements of the care that we deliver. And whether or not you're doing direct care or you're administrative or you're in the community or whatever capacity that you're serving in to help women and their families, there's some really key elements that sometimes get lost in our fervor to really improve outcomes. So Maya Angelou is one of my favorite poets and writers, and I love this quote because it really sets the tone for what we're going to talk about today. And this is really important because I tell my students all the time, even if you're giving a patient bad news, they should still think you're the best doctor in the world. And that means that how you communicate with your patients is key for that. So everything in the room that's happening, everything that's going on, they may not remember, but they're going to remember that you held their hand or you touched their shoulder or you said a prayer or you just did something not to dismiss them. And the comment that was made is to listen, and I cannot tell you how many times patients tell me, my doctor didn't listen to me, my nurse didn't listen to me, fill in the blank didn't listen to me. And so really, I just want to encourage us to really keep that at the forefront. So this wonderful title is not originated from me. So Joan and her team from our Rural Innovation Center gifted me this title. And it was actually really profound and insightful because I could not have come up with a better combination. Now I'm going to date myself just a little bit, but does anyone remember the Care Bears? Yeah, okay, good. That's good. That's reassuring. Now, I noticed the younger people in the room did not say anything, but that's okay. So today we're going to talk about a practice model, not just in the clinical sense, but just in terms of our interaction with our patients and our community. We're going to talk about compassion, our attitude, our resiliency, and our empathy. And hopefully we can kind of work through all of those things. So I wanted to add an overarching goal. We know that maternal health outcomes is what we want to improve, okay? We want less moms to be recorded as having died being related to pregnancy. We also have not yet talked about all the near misses, about things that could happen that don't progress to that fatal outcome. And there are a lot of people that are in that category as well. But the other point that I want to stress today is maternal health equity. And that's a term that I think we need to start using more. And to break it down, I usually am using the words, your health care or your maternal health care or your women's health care should not be defined by demographics or geographics, okay? So regardless of where you live or what you look like or what you smell like in GYN, your care should still be the same, okay? And why is that important? And let me tell you why you're important, and you're already doing this work. But if you're in Telfair County and your patient has a problem and they need something, you have to know someone in Baldwin or a Bibb County or wherever you need to be. You need to know who has whatever your patient needs. And so we cannot get everyone to move to our major cities, but we are the extenders to the care that our patients need. And so I really want you to embrace that thought about how do we improve maternal health equity? How does the care of my patient and my community be at that standard of care regardless of where we are and what our resources are? So I have some objectives here, and I like Dr. Betcher's talk this morning. It's like we have to have these objectives. And so I really will go through all of this, but I want you to know that at the end of the presentation, you will have some objectives that we've reviewed. And an hour, honestly, is not enough for me to really delve into all of this information. And so my students that work with me know that I love to give homework to my patients, and so you have homework. So I really want you to use this as a self-review guide that you can use at home. There are a lot of resources and links that are here. Take your time, go through them, pick out the ones that will be applicable to you, share them with your colleagues, and really use it as a toolbox as you work on what to improve in your community. So I promised myself that I would not focus on the negative, and I actually had a couple slides with some data that I actually took out and did not want to review because you already know things don't look great. But I did want to start out with this one slide that talks about, where our deaths are happening, and you saw that picture this morning. Those patients are probably not in the OB/GYN's office. Now, they may be the pediatrician's office because our mamas will take their kids to the doctor, but they're at the grocery store, they're at the baseball field, they're at the movie theater, and I'm mentioning those places in particular. They're getting their nails done and their lashes. So if we want to, as Dr. Betcher said, really get to where our patients are, we have to go where they are. So if we have a van outside of Kroger and we offer whatever service, then while mom is either before or after groceries, she can do that. And so I know that takes money, I know that takes time, but I want you to think about what existing infrastructure do you already have that we're not tapping into? For example, we have a health department in every single county. We have a place where people are very familiar. How can we utilize that space to really improve our access to care? So start thinking about what do we already have that we can use for our patients. So I love this slide because it's a little cheesy, and I'm not as funny as Dr. Betcher, but I'm going to try. So things are just not that peachy, we know that. But I'm going to move on and start talking about how we look at the problem and then what solutions are already happening that are in place. As you know, this morning, we talked about cardiovascular issues being a significant issue for women. We think about hypertensive disorders, we think about things like cardiomyopathy, where the heart gets enlarged and sometimes remains enlarged, which increases that woman's risk of issues happening later on. And this morning, there's an article that came out that talked about women that have perinatal depression have worse cardiovascular outcomes long term. So really, focusing on the heart, literally, is becoming more and more important about everything that we do. But I want you to know that there's some things that are happening that are very positive, and I'm going to try. Where's Mr. Moody? He's supposed to be hovering beside me. There he is. He's going to rescue me. I'm not very technologically advanced. I do not have Instagram. I do not have TikTok. I don't have anything except LinkedIn. So I'm going to try to play this video for you.
My name is Karen Herbst, and I'm going to perform an exam for lipedema. So the first thing that I do is I want to examine the head. So I'm going to feel the top of the head, and I want to make sure that I'm feeling...
Wrong video, just a second. Nope. Okay. Didn't come up, so let's see what I can do here. Can I disclose this for a second? Okay. Get out. Close out. Let's see if we can do it here. Just a little technological difficulty. So while I'm doing this, I do have a favor to ask of you. I want you to think about something that has gone really well that's happened for your moms and something that has not gone well. And I'm going to start at the table right here in the middle. If you could just share with our audience in maybe one sentence something that has gone well with taking care of the moms that you take care of. I'm putting you on the spot, I know, but I'm working through this technological difficulty. Can you think of anything? Let's see if we can get it.
We had a resuscitation event. We worked labor and delivery, but we ended up recovering with 0 deficits just for our quick response.
Is it not the one in the presentation?
I'm sorry, can you say it again? I didn't hear you. Forgive me.
Sorry. We had a devastating situation that happened. I don't know how much detail I can give. But the baby was expected to have severe deficits. We did a full resuscitation on the baby rather quickly. It was magical because every doctor was in the area that needed to be there in a labor and delivery type situation. And the baby's now 3 years old, no deficits, mom's perfect. Yeah.
Fantastic, thank you.
Where are you from?
Valdosta, Georgia.
Okay, wonderful. And we'll jump to the table that's right behind you.
They're not care providers.
You,
Yeah, we can.
okay?
Very recently, the positive thing, we had a patient who decided to go natural. Her 2 previous children, she had used regional anesthesia and was very successful, very pulled together, and was like a textbook natural delivery. So we're all rooting for her. And then we also had a bad experience with a patient who had a postpartum hemorrhage, and the bleeding was quite significant enough that the patient ended up, that we were no longer able to care for her in labor and delivery. She did have to be transferred to the intensive care unit. But on follow-up, her recovery was better than expected, and within 5 days, she was able to go home.
That's fantastic, thank you.
Where are you from? Piedmont Henry Hospital.
Okay, thank you. And let's go to the table right there. I know it's just 2 people, but do you have anything you'd like to share, challenges you've had, or something really awesome that has come with your interaction, whatever capacity?
So hey everybody, I'm Christina. I'm a doula and lactation counselor and a Black mental health organization founder in Valdosta, Georgia. recently I was able to counsel a breastfeeding mom who was about to give up due to perceived low milk supply, and with just some basic tweaking of her latch and just making sure that the baby was okay, we got her breastfeeding and she's still going. So it was really good. She was the first to breastfeed in her family, so yes.
And then the table behind, I'm gonna put Remy on the spot. Remy's my friend from South Georgia. Our kids used to be in school together.
Can you go back to the?
Hello, everyone. So we had a recent situation where we had a mother that was screened for syphilis. It was her 3rd trimester, so probably her 2nd screen. But it was positive, and she had no interest in coming in to take care of that. So like Dr. Callins said, we have to meet the patients where we are, so we had to go pick her up from the nail shop and make sure she got to the health department so that she can get the treatment that she needed.
Stop
so
the
that we
caring
can
for their
avoid
little ones.
Not
However,
another, but
many
more
new
congenital
unexpected
syphilis cases,
mothers
because
in
unfortunately,
particular-
congenital syphilis is on the rise in Georgia.
Thank you. I will jump over to our next table, and I'm gonna put my other friend on the spot. That's my daughter's best friend's mom.
Good afternoon, everyone. Thank you, Dr. Callins. My background, I'm a pharmacist here in the state of Georgia, and one of the most impressive things that I've been able to see and bear witness as it relates to mothers is the collaboration between pharmacists and primary care providers for those mothers who have concerns about medications that they will need throughout their pregnancy, that they have some reservations about the potential impact or harm that could cause to their fetus. And so being able to connect mothers as a pharmacist, being able to connect that individual with primary care providers and have them receive the information that they need to determine whether or not it's going to be a best course of action to continue those medications to keep moms stable and safe, specifically around the idea of depression, and also provide her with the confidence of knowing that there will be no harm to their unborn child, and see the success of both mom and baby making it full term and both with really great health outcomes. Well, it makes me proud of the collaborations between pharmacists and primary care providers, as well as community resources to ensure that the mother has trusted information that she will take and include in her care for herself and her babies. And basically, I've seen that outcome be that the mother now has an heightened experience and trust with their pharmacist, who's one of the very primary resources in the community, and also seeing the pharmacists and the providers make that connection on their behalf has really made me appreciate the hope in collaborating on behalf of our patients. So that was one of my most recent.
Perfect. Thank you. And we'll go to this table right here, kind of in front of the students. There's a lady in a pretty yellow dress. That's right, that's you. So anyone from that table want to share anything, challenges or successes that you'd love to share with our group today?
My name is Allison. I'm actually a nurse practitioner for pediatric hospital medicine in our community at Tip Regional. But I do work very closely with like our midwives and laborists and cover the nursery. I was actually just remembering a breastfeeding success story after I heard someone mention it. Several years ago when I first started, I went and became CLC trained, and then we had several nurses get trained, so I didn't really get to help as much for the moms, but like she said, we had almost identical situation of just a mom who was about ready to give up. Her baby had lost too much weight, and just spending 5 minutes helping her latch, like completely changed her whole breastfeeding journey. And those are those little success stories that we hang on to because we're making, such a big difference. But one of the biggest, or not biggest, just one of the biggest problems I've seen lately, and I'm sure everyone can attest to this, is we're getting more and more moms, which is where they're having these back-to-back pregnancies. Like once a year, they're coming in. And every pregnancy, they've got the gestational, diabetes, the pregnancy-induced hypertension, and everything's pregnancy-related, but then they never go to the doctor when they're not pregnant. So they're actually, suspected to be chronic comorbidities that are being untreated. And that kind of speaks to, a lot of them are, if they're on the pregnancy Medicaid or state insurance, you know, after that 6-week visit, they're kind of on their own until they get pregnant again. But that, I think someone mentioned earlier about meeting with legislation, and that's just one of those areas that they really, if they could extend it to at least the first year, especially since that's when we're seeing most of the maternal mortality and morbidity problems arising, you know, could we help these moms have a better, help them get in better health in between these pregnancies, or even before they even get pregnant to begin with.
Thank you for sharing that. I do have a comment, but I'm going to wait till everyone's done. We can move to the table in front of that table, and we have 3 lovely ladies here, and one person is being highlighted to speak.
What is going well for me doing Healthy Start is
Can you speak up for me?
what has gone well for me doing the Healthy Start program. My mission was to educate, empower, and show them there were the resources already they provided. And that empowerment thing was something really good because it's a 3-minute video, I can't remember the name of it, but you show it to them initially. And just to see them actually, you know, becoming empowered, actually speaking up some, or, you know, making, I shouldn't say that, not making the doctors listen to them, but sometimes they don't hear them. So that was what's really going well. What really is going wrong is that I will visit my clients sometime in the hospital, and I know they're busy. I worked in a hospital, and delivery and all that, but what went wrong is it just felt like nobody was listening or trying to be there for this client situation economically. Stay in an extended stay partner, people say, why is he not there? He has to keep that job. They only have so much money for gas for him to get to work. She had an emergency C-section, ended up with severe preeclampsia, but thank goodness she called the ambulance because she thought it was food poisoning. She was throwing up for 24 hours. She said she knew, she remembered the hospital. So basically what happened is she had severe preeclampsia, emergency C-section. She didn't know what was going on the next day, and I was able to ask the staff if someone could come in there and explain to her, the nurse taking care of her or whatever. It was the doctor. I was so impressed. The doctor came in there and broke it down, you know, on layman's term for her so she can understand. And I thought that was really good. She ended up with obstruction, so she ended up 27 days there.
Thank you for sharing that. And this actually worked out really well because what we're hearing are some of the things that are not reflected sometimes in the reports that we receive. But this is the real life stuff that we are encountering. And we're working through those things. And before you leave today, everybody needs to make a new friend because there are things that are happening everywhere that we really need to be sharing. So thank you for that. You can pop over here. Mm-hmm. Yep. Got a lot of people at this table. Who wants to go? You're the chosen one.
We're all from the same organization.
Okay, what organization is that?
It's Oaks Regional Medical Center in the rural town of Thomaston, Georgia. And we're very proud, we just became designated with the DPH as a level 2 maternal center. So, and we're also level 2 special care nursery. So for our community, that's really big, and we're very proud of that. But in becoming and going through the transition to get that verification, we've gotten lots of education, mainly and importantly for our ER physicians and our ER staff to get those women that are coming in through our emergency department that quick and timely consultation with our OBs. And so it's become a good, all around with our organization.
That's fantastic. And you also are the former place for Dr. Joy Baker.
Yes.
Right? She was actually one of my junior residents. That's how old I am. I taught her. But yeah, I know she used to be there. But thank you for that. Okay, we can pop to the table in front. So someone here is going to speak to us.
I'm Heather Daniels. I'm the labor and delivery director at Liberty Regional Medical Center. And I'm very proud of our work. We have a follow-up program that we've created at our hospital for all of our postpartum moms. Anybody with high blood pressure, anybody on blood pressure medication gets cardiology follow-up. and they get enrolled in our MHM program, and they have real-time monitoring at home. So they have access to us 24/7, and we have a great care team between our cardiologists and our OB docs. So it's a great program.
Thank you. Right here. We've got three lovely ladies here. I'll spare Ms. Prime because she's going to speak to us.
I'm Yvonne Fiss. I'm from Robbins Air Force Base. Do new parent support program. We do home visits.
Okay.
I had a client that was a registered nurse, had her second baby, had some blood pressure problems delivery-wise, came home, and I was educating her about maternal death with the blood pressure, and she's like, no, I'm cool. But with encouragement and her mother being there, she went to the ER, and the doctor said, we're not worried about the blood pressure, and I told her no. And so finally, after, she had to literally go to her primary care doctor because the OB doctor didn't do anything either. And then finally was put on some medication. And that was, by the time she really had problems, it was 60 days. And so I was explaining to her, well, her husband's deployed. I said, so what would your children do if you don't make it? And she said, you don't have to put it like that, but she didn't receive any discharge planning about her blood pressure, wasn't educated about following up on her blood pressure, and we're starting to see that a little bit more, that they're not being told to follow up about her blood pressure after the delivery, but she's doing well. They just, PCS, which moved to Texas, and she's working on oncology, so.
Okay. Fantastic, thank you. I'm taking notes. I have lots of thoughts.
Hi, I'm Leah with Nurturing Lactation Care, breastfeeding specialist. I'll start with the negative, and then I'll end with a positive story. So recently I had a client who had all indications of retained placental fragments, referred her to her obstetrician, who declined to order an ultrasound. So this put the mother in a very difficult headspace of thinking that there was something wrong that could be fixed and not having access to the care. So that's the negative story. That's a story of the team not working together. But on the flip side, I have more good than bad experience with that. The positive is recently, in another specific situation, I had a provider who was recommending supplementation for a breastfeeding mom, and got a call for me to come and help, and I was able to help her understand that we've got to feed the baby, you know, and we were able to work together, and with strategic formula supplementation along with proper lactation management, she's now exclusively nursing. So that's an instance of the team working together.
Thank you. And I think we have, is anyone at this table wants to speak? Anybody? Would you, in the pretty midnight blue?
First, I'm glad to be here. I am in Albany, Georgia, so you know we deal with a lot of mothers, young mothers especially, and they are not receiving the resources or they don't know where to go. So my goal in the community is to direct them and walk with them through that mission. I just became a doula, so I have 2 clients, and it amazes me the lack of information. It's not that they don't care, they don't know. I don't know a lot of sad stories other than well, they are sad, but where mothers have died in our hospital, young mothers. But I feel if we were to step into that space and be that big sister role and guide them, because having my baby, I can go back. I had my second child. I gave birth to her with no doctor in the room. They released me. I got home, I called him, I said, Dr. Edwards, will you please not let me die? My bed was saturated. He left the placenta inside of me. So I had 2 babies in car seats that I had to go back to the hospital with while they remove it. There needs to be change. We know the sad stories. We know the problems. But when are we gonna step together and become the solution? I'm tired of talking about it. We're here together. So we are the voice and we are the people. I ain't gonna talk about it no more. I'm gonna step in those spaces.
Thank you. Is there any table that I did not address? I know we have a lot of staff at the table in the rear, but if anyone does want to speak, I don't want to decline you of that opportunity. So last chance, going, okay? Perfect, yes, please.
She's my other co-star.
I'm vocal, and I'm gonna take up space. Cassandra, I just wanna shout out both me and her and for what we've done with our community. Both her and I graduated from the Center for Maternal Health Equity as perinatal patient navigators for Morehouse School of Medicine, and we, along with how many other, maybe 14 of us, are doing real work in rural South Georgia and to improve the birth outcome. So yes, I just want to highlight that. And Morehouse School of Medicine, thank you.
Thank you. So that little detour just worked out really well. Do I even have to do my presentation? I do. But I want to, first of all, let's give everyone a round of applause. Let's do that first. And I have my video ready, but I wanted to just start out by saying, I really hope our medical students heard every single story that was shared. And it's unfortunate. Our kids don't listen to us, right? I mean, I have 2 kids, and I should tell you, they read my bio, but the most important thing you should know is I have a 19-year-old and a 15-year-old, and they're still alive. So that gives me credit for something. But we really have to work on how we engage with our patients, how we listen, and how we get the support that they need. And in several stories, there's some commonalities. I reached out, and the appropriate thing may not have been done. Now, there may be some other information that we need to have to decide kind of how that happened and who didn't get the message and who didn't get it on time. But we really have work to do. That is not medicine. I tell my students all the time, you're in medical school, 30% of what you need is actual medicine. The other 70% is how we interact with each other, how we utilize resources, how we listen to our patients, and how, if we don't know something and we don't have what we need, how do we get it for them? Does your patient need you to go to the moon? Call up whoever you need to and get on a rocket and go to the moon. Empower, I love that, and we're going to talk about it in our presentation today, because this is more than just fixing our patients. When we empower and educate our women, as you mentioned, they do what they do best. I tell people all the time, when moms dazzle, everybody shines. So if we help our moms feel well physically, mentally, and emotionally, they will read to their kids, they will feed them veggies, they will take them to play in the park so they don't get overweight. If we help our moms do well, they will take it from there, right? Breastfeeding was mentioned several times. That's a very key component. I like to use the word lactation. You know why? My son did not latch on when I birthed him. I was an exclusive pumper, so he got breast milk, just not from me. My daughter, different story. You meet her, you'll understand why. She's a different child, very focused. But how do we empower our women so that if they're not able to breastfeed, can they pump? Or do they need to do both? Or how can we make that happen? I have a lot of patients that are having breast reductions early. And so they are not counseled very well or understand the difficulty that might show up when they decide to get pregnant and are having a baby. And so that's the provider's responsibility to make that assessment during their prenatal care, provided they've been able to come in. So you can prepare for that, because they may have milk, but if the architecture has been compromised, they're not gonna be able to breastfeed. Their frustration is high, and they're going to feel like they're a bad mom, like I did when I could not do that very well the first time. So we've got work to do. I love the comment about the repeat pregnancies. So what needs to happen in our postpartum period is our mental health, but our contraceptive education. And honestly, the conversation for contraception happens before they deliver. So I ask my moms, what are we doing? And some of those things, depending on the hospital system that you're in, you can do that in the hospital. I've had patients come in when I worked at Phoebe who I call them a flight risk. So they never came in for prenatal care. It's baby number 5. Do you think I'm going to let them walk out without something? Absolutely not. Nexplanon in the arm, 3 years, spacing. How do we do that? How do we make sure they have access? A lot of talk about the social determinants of health. Really being able to assess that, as you mentioned, resources, transportation, and just imagine having an emergency C-section, and then your husband is the only one who's working, and then you're not feeling well, and then you've got to take care of your baby, and then you're supposed to smile while you do it. Impossible. Unless the village that we have can really address that. The emergency room, I love the comment about involving emergency rooms, because a lot of times, especially in our rural communities, our moms may deliver at a tertiary care center, but they live in a rural town. So when they have a problem, they're going to the nearest ER. So do our docs know how to recognize? Do they ask the question? Very simple. Have you delivered a baby recently? That changes the paradigm if we are asking the question. Preeclampsia was mentioned quite a bit, very common, and I cannot tell you how many people have issues before they leave the hospital. Oh, you'll be fine. I've heard it over and over again. And so as a clinician, we have a responsibility to do a better job. We want our patients to be educated, we want our families to be educated, but we also have to listen and recognize the symptoms. And we don't need more blood tests to do that. We just have to pay attention and respond appropriately. Advocacy, I love what you said. Patient had a problem, what do? Find somebody who will listen. I had a patient once, I was in Albany at the time, she had a dental procedure, she was like 32 weeks, developed an abscess. The hospital where she had the procedure, they refused to see her because she's pregnant, but they took her tooth out. She had a retained tooth, a portion of it. Her mom drove her an hour to Albany, and I found a dentist who agreed to go to the operating room and clear that abscess for her. So we have to advocate for our patients. And if we don't do that, we're going to lose more moms. So if your voice is not loud enough, you go find 10 people and you make that voice louder. Like the walls of Jericho, they will come down. And last, just information. And I do think it's kind of crazy because we're in 2024. So why don't our women know that, right? We talk about clothing, we talk about movies, we talk about, everything else. So why are we not communicating with our moms as much as we should to make sure that they're not surprised by things? So we have work to do. We don't need an action plan. We don't need a call to action. You heard everybody's comments. And so now when you get back to your community, just start thinking about how we can do that differently. So now I have the video. So we're going to start. So we talked about high blood pressure being an issue postpartum. Heather did a wonderful job of kind of introducing, but I'm going to show you a quick video because I want to tell you the change that we want to come is happening. We just need it to happen faster and happen everywhere. So hopefully, if this doesn't work, Mr. Moody can come and save me. Okay, we're good.
There's nothing that can match the joy of bringing a healthy child into the world. New mothers immediately have their lives altered as they adapt to caring for their little ones. However, many new and expectant mothers can be particularly prone to serious and even critical medical issues, especially regarding their cardiac health. Additionally, the rates of these occurrences have disproportionately affected populations in rural or potentially underserved communities. In a time period where the child's health has historically been prioritized, many realize there needs to be a concerted emphasis on the well-being of mom. Some of the things that happen immediately postpartum while you're in the hospital is usually related to bleeding issues or postpartum hemorrhage. Those are the ones that we see, we can address. The other ones that sometimes are a little bit more delayed in terms of presentation are related to the heart. That can show up in several ways in terms of preeclampsia, or they've had chronic blood pressure issues, they can worsen and become concerning. And then cardiovascular issues, either they're pre-existing or they suddenly appear after delivery.
Women have a whole host of issues that they deal with during their pregnancy and right after pregnancy. Peripartum cardiomyopathy is actually a big one. That's when your heart muscle actually weakens, it gets a little dilated, and instead of pumping like a strong pump, it pumps very weakly like a big sac. A lot of these issues are genetic. There's certain populations that have some predispositions to it. Another issue that's a big one is hypertension during pregnancy. Preeclampsia, which is kind of an extreme case of that during pregnancy. during the pregnancy and right after the pregnancy, that can cause a lot of complications, including loss of the baby and loss of life for the mother.
The statistics show that people in rural areas are poorer, sicker. They do not have the resources of all the specialties that some of the larger areas have. So a lot of times the lack of resources in those areas for specialty care is not provided.
I already had high blood pressure prior to being pregnant. It was all managed well after my pregnancy, but 1 week after delivery, I started noticing changes in my body. I had difficulty sleeping. I couldn't lay down flat, and I had some fluid retention. My blood pressure was normal up until that point, and I remember my brother come to visit with me, and he said that he noticed how swollen I was, even my nose, but I hadn't even really paid attention. I just knew that I was so tired that I couldn't hold my own thing. And that evening I checked my blood pressure, it was high. So I went to the ER and the doctor did a chest x-ray and found fluid on my heart. The next morning the doctor told me that I was diagnosed with postpartum heart failure. And that was difficult to hear since I'd just given birth to my first son and had to leave my home. That day, a cardiac nurse came and approached me about the Mom's Heart Matters program, and I was enrolled into the program prior to being discharged from the hospital. And with that program's guidance, I was able to create a better lifestyle for myself to minimize future damage.
The Mom's Heart Matters program, supported in Hinesville, Georgia by the Liberty Regional Medical Center, is a new creative solution to help curb postpartum medical problems in new mothers and was designed to save lives.
Depending on what people have in terms of access to care, it differs in different communities. There's also a feeling that if you're in a rural community, maybe the quality of the care may not be the same, and so they may not want to stay at home and do that. But I think with time and with programs like Mom's Heart Matters, we can demonstrate that the circle of care and the network that we can provide really is not just about the pregnancy, but what happens afterwards. And one of the really cool things about Mom's Heart Matters is our program and our monitoring and our resources don't stop at the end of the 6-week period. It doesn't stop at the end of 3 months. We actually are following our moms for the entire year.
The biggest misconception is once the baby is delivered, all is well. That actually is one of the most dangerous times for the mother and her heart right after the baby is delivered. The challenge here is to educate people that you gotta take care of yourself. We have individual stories and data that suggests we're helping save moms' lives. And I think as people see that, there's gonna be more buy-in with other physicians, other doctors, other nurses. What we have here that's really beautiful is a lot of commitment and a lot of energy that care a lot about this program.
I'll go in there and I'll explain the program and how important it is for med management and med compliance, taking their medicine when they're supposed to, and we'll discuss the side effects. And you don't take care of yourself like you're supposed to, what the consequences could be, since they do have preeclampsia and high blood pressure, the effects that that could have on their bodies and their lifestyle if they did not take the medicines and be compliant, how important it is for them to do that. And we'll go through education, do their enrollment, we give them their blood pressure cuff, and those cuffs, as long as they have cell service, then we can see their blood pressure anywhere they are, 24/7. We download the app to their phone with them. We go through how to take their pressure with the cuff. They take it in front of us, so they demonstrate how to use it. And then we make sure that they can see it on their phone.
We've actually seen the results and have had several patients say, I believe you saved my life. And we know that we've made a difference, that their cardiovascular disease has been maintained, if not prevented. And that's really our overall goal, is to make a difference in a patient's life.
To learn more about Liberty Regional Medical Center and for information on the Mom's...
All right, thank you for indulging me. Now I'm going to see if I can get back to the slides, which I think I can, maybe. Let's do this. So I really wanted you to have a positive story for how we're really working on improving. And Heather is here, and also Donna from our administrative team. And so if you want more information about that, we're happy to share. But you don't have to duplicate that program. What we're encouraging people to do is to really think outside the box and how we solve those problems. And we found a way to do that. And we actually found some money to do it too, which is great. So let's jump into our presentation, and I'm kind of glad that we had the extra 15 minutes to start because we had a chance to have that session, which worked well. For my students that are here, and for those of you that know me, I love to read. I have a book addiction, I think. And so for every section that we'll talk about today, I will mention some books that I highly recommend. The Compassionomics, actually, Dr. Sumna just let me borrow hers. We have a book exchange. And The Power of Lift is a fantastic book that I would highly recommend that you look into. But the first topic is going to be about compassion. And we want to discuss, and I use this term, and I felt so proud of myself when I thought of this word, bidirectional benefits of compassion, because it really impacts both the receiver and the giver, right? If you feel really depressed, you go somewhere and you take care of someone, or you give your time, or you volunteer, you usually feel better, and also you've helped someone else. So there are definitely benefits for both. And we also want to think about strategies to address compassion fatigue, because what happens a lot of times is, for those of you in the room that mentioned how much you're going above and beyond to help your patients, you have a lot of patients that need that same support. And so it is easy for you to get tired and maybe a little burnt out. And so we want to talk about those things. So I want to start out by just sharing a quick story. I love to tell stories too. And I'll be sensitive to time, but I have to tell you this story. So in The Moment of Lift, the book that I mentioned by Melinda Gates, is a story about a doctor who went to a small, very rural town, and he went to the town, and he was very scared to go to the town because he had had a maternal patient from that area who had died. The woman had come in, they had driven like a day or so, she was bleeding, which is crazy to think about, but they drove, got him there, and apparently it sounded like a shoulder dystocia. The baby was stuck. So in order for him to deliver the baby, he had to dismember the baby, which was already dead. And then in the process of that, the mother did not live because she had already lost all her blood. And so it's interesting because he remembered what happened, and he was really terrified of going back there because, you know, when things don't work out well, people go after the provider. And I want to read a section that I think will kind of illustrate the importance of compassion, if you'll just indulge me for a moment. You went out of the room into your yard. You stopped the vaccination car from leaving. You ran to catch up with it. You made the car come back. You took out boxes from the car, and you arranged for the woman from our village to be wrapped in a white sheet. You provided the sheet, and you even provided a small sheet for the pieces of the baby. Then you arranged for the woman's body to be put into that Jeep, and you made one of your staff get out there so they would have room for the brothers to go with her. So after that tragedy, she was back home the same day while the sun was still shining. We had the funeral that evening, and her whole family, everyone was there. We never expected anyone to show such respect for us poor farmers here in the forest. You are deeply respected for what you do. Thank you very much. You will always be in our memory. They respected that doctor, even though he was not able to save that woman's life, but because of their culture, he was able to return that dead body, and they were able to bury that woman and her baby before the sun went down as part of their culture. So when I think about compassion, I think about how do we interact with the people that we're taking care of, even if the outcome is bad? What little thing can we do to help preserve their dignity in that scenario? And so I like that backdrop because, when you think about your self-check questions regarding compassion, who should be dispensing compassion? What should that look like? When should you offer it? All the time, obviously. Where should it happen? Anywhere. Why should you do it? Because it makes a difference for that patient in that difficult time, but it also makes a difference for you. And how do you do that? And it just depends. So when I walk into a room, I had a patient that I saw this week, and as I opened the door, I saw her fanning. So she's postmenopausal. And so I said, would you like some cold water? And she said, yes. And I said, great, I'll be right back. That's compassion. She's hot. I could walk in the room, I could not do anything, I could still do my pap smear, and she could still think I'm fine. But I noticed she was fanning. And so the immediate translation is, what do I need to do to help her feel more comfortable? Now, I was kind of being a little selfish because I had 3 medical students with me. Well, 2 medical students and 1 person shadowing. And so I said, well, if I give you this water, will you let my students come in the room? And so, of course, she agreed. She was thirsty. But so I do leverage that a little bit. But what I want is for everyone to think about, when you meet someone, assess the situation. And half the time, actually more than half, we don't know what is really going on with that patient. If they are rude to you and they're acting crazy, which happens, there is probably a reason. Now, is it legitimate? Debatable. but you don't know. You don't know if their dad is in hospice. You don't know if their mom just passed away. It was Father's Day this weekend. You don't know what's going on. So assume you don't have all the information. And it's important for you to just stop and think and be responsive to what you are seeing. That's not medicine. That's just human care. That's compassion. In addition, I talked about, compassion fatigue and really how do we work on that? And I think probably the best thing is our community. So if you have a difficult patient, you've got to have someone that you can talk to about it. So you can share that with them, you can let it out, mostly because you don't want to take that home if you're really distressed. But also, talking to someone who's not already familiar with the situation may give you some insight about how you may even address that problem. So really how we build that community of care. And so I think when it comes to compassion fatigue, we have to realize that it is not a single person job. It is a village thing. And so we have to utilize our village. And I love the quote that says all the time, you cannot pour for an empty cup. And so, or if your cup is too full, that might be an interesting too. But if you are giving compassion all the time, how do you refill your cup? And a lot of times that happens by connecting with other people who can help to energize you and remind you of how awesome you are and why you're doing what you're doing. So my argument today, and I'm speeding up a little bit because of our time, is compassion really needs to make a comeback. And what's happening in our medical community right now, we have a lot of patients who are avoiding the hospital. They're avoiding the doctor until it's too late because they're worried they're going to go and they're going to send them back home, or somebody's going to look at them and they're going to make an assessment and they're not going to get the level of care that they need. We are the front faces of that. And so that means we have to start changing the culture, and we have to really help it to, and I have make compassion culture go viral, what that term means in our social media world. But we got to be kind. We've got to really make sure our patients know that we care. And if you're involved in the community, you're involved in patient care, we know you care because you signed up to do this. Like, you could do so many other things, but you decided to pursue this. And so how do we make sure that we are displaying that to our patients? And the last point I'll make as I move on is that, I talk a lot of times about building bridges, but also when it comes to compassion, we're repairing bridges. You have people that are coming to you that they have not been listened to before. They're expecting you to do the same thing. And so if they have a wall up, you may have to think about, well, how do you repair their perception of what their medical experience needs to look like? And you can absolutely change that. It doesn't matter if they've had 10 prior terrible experiences. All it takes is one life-changing moment for someone to say, how's your day? What did you have for breakfast? I like your shirt. Your earrings are cute. Something. But just make sure that the patient or the person you're taking care of really understands that you are thinking about them and not just their problem. What role does compassion have in healthcare? A lot of things. That goes without saying. But as I mentioned before, unfortunately, we have gotten so focused on solving the problems that we forgot the person that has the problem. And so I just really want to encourage you to notice what's going on, really respond to how they're feeling, and just see whatever you could do. And a lot of the things that will make a difference don't require a lot of money, don't require a lot of effort. It just requires your ability to acknowledge that. Another book, I told you I love books. So I'm reading this right now, The Light We Carry by Michelle Obama, which I really love. I just finished reading Becoming. Actually, I finished reading that book the day that her mother passed away, which is interesting because I felt like I knew her because I read the book. But I want to talk about attitude. Now, if you have a teenager, if you've been around teenagers, what attitude looks like, okay? Or, yes, amen. You've encountered someone who just really has a bad attitude. And attitudes, and I'm going to add beliefs, so you can use the word abs, like, your stomach. But attitudes and beliefs absolutely impact how that patient receives your information. So you can have good information, but if you're throwing it at your patient as if they have no prior knowledge, or they don't know anything about what you're talking about, or you're suddenly enlightening them, that is not going to go well. And patients are very perceptive. And so one of the things that I think is important is for us to really work on that. I use the word healthcare ecosystem on purpose because I want you to think about the broad picture of really what healthcare involves. And we need to really check our attitude because it impacts what we do and it impacts how we do it. And if we don't work on how we engage with patients, we will not be able to rely on them sharing with us the things that we need to know so that we can actually help them. I cannot tell you how often, and you've probably had this where you're talking to a patient and you find out about something 5 minutes in, that if you had known that earlier, it would have helped you and it could have even expedited what you're doing for that patient. So the attitude that you walk into the room with is important. And so if you feel like you're going to encounter a difficult situation, I do it all the time. I will stop and I will say a prayer. And I say, Lord, help me to have the right face, the right attitude. You know that scripture, let the words of my mouth and the meditation of my heart be acceptable? Say it out loud if you have to. Because sometimes we do have people who will try you, right? But you do not have to match the crazy, right? Our responsibility is to help our patients. Even if we're not sure how to do it, we have to approach it with that same attitude. I want to really promote the patient-centered paradigm. A lot of times we're going in and we're developing programs and we're developing things, but we haven't asked the people who receive it. So if we have a focus group, we decide we're going to do it at 4. Well, what are most parents doing at 4? Picking up their kids, or they're going to the ballpark. And so is that the best time for us to do that? The only way that we can know that is to ask the parents who will be receiving the care. So you may end up with 2 sessions. The moms who don't work may come in the morning, the moms who do may come in the evening. So really thinking about how we're designing what we're doing. I want to really touch on creating circles of care, which was mentioned in the video. So as I mentioned before, regardless of where you are, if you don't have everything that your patient needs, you've got to know who has it. So I had a patient last week that I saw that had severe postpartum depression. I mean, she would not crack a smile the entire time. I delivered her by C-section 3 weeks prior. And so it was Friday. And so I tried to do a referral for therapy, but you know, it's Friday and they close at 12 and everybody's gone for the weekend. So I did put the referral in, and then I reached out to, and I don't know if we have anyone here from First Steps, because they'll do home visits and really help the patient, so I did that. But I called Peace for Moms, and you're here. If you don't know Peace for Moms, I want you to Google it. So it's a service where any provider anywhere in the state can call this number, and within 30 minutes, a psychiatrist will call you back and they will help you with your patient. Put her on speaker, so I'm checking her incision, which looked good. I did a great job with that. And then the psychiatrist was evaluating her. I was able to call her medication in. I had her sit in the room because she needed FMLA papers, and I said, well, the office can do that. By the time you're done, I want you to pick up your medicine. Did I send the prescription through the computer? Do you think that's what I did? No. I called the pharmacist myself. And I said, this patient's going to be there in an hour. Can you get it ready for her? She said, I have to do grocery shopping. Great. So that means when she's done with the office, by the time she gets there, she can do her grocery shopping. She can pick up her medicine. She can go back home because she has 3 babies at home. Okay? That's compassionate care. That's attitude. Okay? Now, every time you encounter a patient, I want you to start thinking about, how do I really set things up for this patient? So that was not medicine. I mean, I made the diagnosis, I got the medicine, Dr. Goldsmith did great. But then if I had not done those extra steps, that patient might have gone home. She doesn't have anyone to watch the kids. She's not going to pick up her medicine till later. All those other things. It is extra work, yes. All of your patients will not require extra work, but it's our responsibility to figure out, once we encounter that particular patient, what do we need to do to help them? And if they need extra, you give them extra. If they need less, they need less. But the attitude to how you approach that patient is extremely important. There's a book that I love, The 7 Habits of Highly Effective People. I've kind of borrowed the term, The 7 Habits of Highly Effective Healthcare Team. And one of the points that's mentioned is how you begin with the end in mind. And that means approaching the patient with the outcome that you want them to have. Keeping in mind, our statistics for Georgia are terrible. I have people telling me, I don't want to have a baby in Georgia. I was like, don't leave us. We have peaches. That's not going to work. But really, our attitude to healthcare really is important. And so I know that you know this well, and I don't know that anyone is particularly guilty. But the culture that we have right now, a lot of our patients are avoiding the healthcare system because they feel like they can do better. And there are a lot of patients who are not well or who do need assistance and are going to be negatively impacted if we don't do that. So with that, I have a couple of links at the end. Like I said, this is going to be your work study homework project. So please take some time when you're drinking your sweet tea well, not outside because it's too hot, but whenever you do take a break. The book that I mentioned before, and there's another one that's called The 5 Practices of Exemplary Leadership. So just more book recommendations. Resiliency, I want to talk a little bit about. The other word that works really well for resiliency is bounce back ability, which means when something does happen, how do you respond? And I want to talk to you about that from the standpoint of the healthcare system. So when you run into a problem, how does the system respond to that? And I'm going to jump to, I think, number 1, 2, 3, 4. Allow your challenges to become your channels. A lot of the things that I know and a lot of the resources that I'm able to be aware of is because with a patient, I've run into a roadblock. And so that roadblock means I have to create a door. And that means I have to reach out and I say, do you know this? Or who can help me with this? No one person knows everything. And so one of the things that I hope we'll be able to do going forward is really being able to have everyone that's here form some kind of directory. So that way we would run into something. If we had what's the fancy thing? A group me or something. We could say, I have a patient who does this and they need X and where can I get it? And so we have a lot of resources, but the left hand does not know what the right toe is doing. I didn't do the head on purpose, so you're paying attention. So I want to tell you a quick story about the MHM here means menstrual hygiene management, which is a fancy word for period products, okay? So I'm working in Twiggs County, and I didn't mention in full disclosure that I am with community healthcare systems, and I'm the only doctor in my county. I've been the only one for almost 8 years. So that's why I have all those med students back there. I'm trying to brainwash them into coming to Twiggs County. So we started a program because I noticed that I had 3 students in one day who came in for work excuses for heavy cycles and needing to go home. And so I went to the school and I said, how many people do you leave school because of a cycle issue? And the counselor was very proficient, was able to look up and tell me the previous year they had 61 days of missed school because of cycles. Now, you know that if your cycle is on and it's heavy or you're hurting, you cannot learn. You cannot concentrate. You want to be in your bed with a hot towel on. So I decided that we would work on providing some support for the school, which we started to do. So shortly after, we were able to get a donation actually through Mercer. The medical students and the period club at the undergrad school donated. We got pads, tampons, panty liners. We got black leggings of all sizes and underwear. So we had all the stuff that we gave to the school. And then what happened in 2020? The world ended, kind of, sort of, briefly. The pandemic hit. And so then all the kids were at home doing distance learning. And so I was still thinking to myself, well, the girls that are having cycle issues, they still exist at home. And if they were not able to afford products prior, they're still having the same issue. So I was able to speak to the school counselor, and I had a couple students with me at the time, and we did what I call the pandemic pivot. So the buses were driving around to provide internet access for students because it's a rural community, but they were also delivering lunches in what the used grocery bags, like from Kroger. So she was able to identify the same girls who were needing products. We did a separate bag with their products and sent it home along with their lunch bag. Nobody knew what they had, but they were still getting their things. So that is an example of resiliency and responsiveness. Something happens, something changes with these days. It could be any day you wake up, something different is happening. So what are we gonna do? If a detour does not mean it's a dead end. If you run into something with your patient, how do we really move forward? So I encourage you to allow your challenges to become your challenges and pivot when you need to. It may happen several times. When you think about resiliency, you would think about the personal stuff. And so people think more yoga. Yoga's good. I do yoga on Wednesdays, 5:45. You can join me. But a lot of times the things that we need to do to help us are really systemic. Do we have leadership from our hospital that can allow us to do the things that we need to do? Do we have funding to allow us to have the extra support that we need to get the supplies to help our patients? And so that resiliency and responsiveness really needs to happen both on an individual level, but also at institutional level. And it is up to us to advocate for the people that are leading our organizations to do that the way that we want them to, right? We can sit here, we can talk about it, but if we're not pushing or making sure the people that are in charge really hear that, then those things will not be different. Advocacy, we talked about earlier with the comments that were shared. If your patients go to the doctor and they do not get the right response, they got to go somewhere else. And I have said that over and over again, no disrespect to my colleagues, but there are good doctors, which was mentioned here, there are good midwives, there are doulas that will help, there are nurse practitioners that will help. There are PAs or physician assistants that can help. Any available person that is willing to help, we need to find them. And hopefully with time and us really communicating, it will be less difficult for us to identify those people if we have an issue. And the last thing is leadership in living color. Leadership is just not about who's running the organization. We're all leaders. And so when we encounter things with our patients, we have a responsibility and we're accountable for really leading the charge. And sometimes it's easy and sometimes it's not. Now, I will tell you very briefly, there are different kinds of leadership, right? So if I say the building is on fire, let's jump out the window, that is not an opportunity for a meeting, right? We need to all jump out the window. Now, if we're changing the colors in this room, then we may be open for discussion about that. So as leaders, it's important for us to really think about how we mobilize the team that we're working with. Are we willing to be leaders but also helpers? Are we willing to roll our sleeves up? If I'm walking down the hall and there's a piece of paper on the ground, am I going to call environmental service to pick up the piece of paper? No, I'm going to pick it up. So we have to figure out how we interchange with those different roles. And a lot of times, servant leadership is very effective. The staff that I work with, they're amazing. To the point now where if I am not in the office and something comes up with a patient, they'll figure it out and they'll say, Dr. Callins, this is what we did. Amazing. When you model that leadership, everybody else gets it and then they do it too. That's your front desk, that's the nurse, that's whoever's answering the phone, that's the people who's cleaned the building. But that leadership is so important to help. And if there was ever a time in our maternal health crisis, even though I don't like the word, that we needed good leadership, it would be now. And so as we're thinking about statistics and we're thinking about things that need to change, our leadership is a very big part of that. And so I want us to move, as you said, to action and not just talking about it. There's another good article that I have at the end that you can review that's talking about resilience and having strengthened the healthcare profession, which is really important. But you know, if we survive the pandemic, we can pretty much do anything. I mean, that was really bizarre, right? So as we approach and think about maternal health equity, we can do that. We're doing it. We just need to do it faster and we need to spread it a little bit more. This is another wonderful book. The medical students will really appreciate this. It talks about the unseen body. There are lots of comments in here about empathy that I really think are important as we get into our last segment. And I'm moving really fast. We're doing great. So I want to talk about clinical empathy and what that means. And the best story I have of this is a former president who was a very good athlete. And he was doing this race that he won every year. And there's another child who was probably about 3 times his size who was also doing the race. And so as he's doing the race, there's a barrel portion where you have to crawl through a barrel. And he turned around and the boy that was crawling through the barrel was stuck. He was too big, so he liked lunch, apparently. And so he stopped and he helped that young man, and he, of course, did not win the race. And so years later, that story was told to the writer of the book, and why did you do that? Why did you help him? And the response was, if I were stuck in a barrel, I would want someone to help me. So when it comes to empathy, like I tell my students all the time, treat your patients like the family you love. I used to say family, but you might not like everybody, so I got very specific. If you wouldn't say it to your grandmother, do not say it. If you would not do it to your sister, do not do it. It is not very hard. And I think a lot of times what we've done is, I think they teach in medicine to be professional and don't connect. But if you connect, you probably would not have labs done at 3 a.m. because they would be sleeping. You would say, let's wait until breakfast is served, then you can get the lab work. That's the kind of thinking process that I want us to really start to expand to involve. And that's what empathy is. In addition, I've added, this is my new term, empathy burnout, because you can get so concerned. I have one of my students tell me I think she calls it empathetic crying. What did you call that? When you cry when other people cry? And so that happens, and it gets really sensitive, especially when women's health, right? We take care of women. They're very emotional, right? I can say that. I do this all the time. And so I actually have a rule in my office now. I don't fuss on Mondays because it's my long day. I only allow people to worry on Wednesday. Literally, I have people write their worries on a sticky note, put it on the fridge. You can worry and then you have to throw it out. But most importantly, I only allow people to cry on Friday. Because if they cry, I cry. But on Friday, I'm going home. So they can cry all they want, which is fine. So again, just really thinking about how we connect with patients. And there's some experiences that we will never be able to share. We may not want to. I have patients with breast cancer, parents with ovarian cancer, parents who have lost a child through their delivery. There's some experiences that you are not ever going to be able to say, I've been there. But you can listen and you can extend a hand and you can really try to help them. You can draw from what you know from other people that have worked for them, and then you can offer that same comfort. So I don't want us to ever get to the point where we think we cannot help someone. We can always help. And even if what we're doing will not change the outcome, we can impact the journey of what the patient is experiencing. And sometimes what we're doing is not just for the patient who may be on their deathbed, but their family sees that. And that's what makes the difference for them, thinking about that. I like this new term. I like making up acronyms. So stigma stripping strategies. So there's a lot of stigma going around that impact the decisions that people make. How much we share, how honest we are, how transparent we can be. And I love the A word, how authentic can we really be? And so it's important for us to really slowly change the culture. And if you see something that's happening that you know should be done differently, you have to say something. Now, whether or not you say it right then, if it's appropriate, is up for discussion. But a lot of things that have been able to persist in terms of our healthcare delivery is because we're not really stepping up and talking about things that need to be addressed differently. It doesn't have to be rude or out of place, but there's now time for us to step up and do that. And then, of course, I want to talk about the team. The opening presentation this morning, Dr. Betcher really talked about the healthcare team. And that team is not just the medical team, not just the clinical team. It's the nurses, it's the phlebotomists, it's the social worker. Everyone that's involved that touches that patient is part of that. And so we really need to be thinking about how we're engaging everyone to use that care model. And I'm getting ready. So if you have questions or comments or thoughts, start thinking about them because we're going to wrap up. And I think I'm going to need Mr. Moody again to help me. I have one more video for you. I might have it ready to go, but he's going to come and help me out. Okay, I think I got it. So this is actually my nurse that you're looking at here.
Partner for Preconception Health in Jeffersonville, Georgia, a case study video. This video was created by the Reproductive Health National Training Center, RHNTC.
My name is Dr. Keisha Callins. I'm an OYN with Community Healthcare Systems here in Jeffersonville, Georgia. Community Healthcare Systems is a federally qualified health center network here in Central Georgia. We have the opportunity to also provide services to the Georgia Family Planning System. Besides the health department, which is a partner for a community, we are the only facility that provides medical services. In addition to the nurse practitioner that's on staff, I am the only physician that's been in this county. And I've been the only one for almost 7 years. But it's such an honor to be able to serve in the community because without that, a lot of our patients will not have access to health care. It's very important for us to be able to provide birth control and do family planning. And a lot of that sometimes is more preconception counseling. And so not just focused on the prevention, but the planning portion of what needs to happen in terms of women's reproductive health.
My name is Cindy Jackson. I'm a registered nurse with Community Healthcare Systems, and I currently serve as quality coordinator. The staff have to have buy-in. Everybody has to understand the mission, the goal, why we come to work every day. Behind every number is a patient. And every time we can improve quality outcomes, we can improve patient outcomes, which not only affects patient lives, but their families and also the community.
The birth control is really just that connection point, but really the lens is how can I improve their quality of life? So the other opportunity that comes up with that preconception visit is really the opportunity for patients to share things that are going on with them that might not otherwise be addressed.
We also do an assessment of the patient's social determinants of health. Because as we know, if the basic needs are not met, if the patient doesn't have food, water, electricity, which a lot of times, unfortunately, we do see patients daily that have those needs. So if their basic needs are not met, that's the groundwork that we've got to start first.
So one of my favorite quotes is, change happens at the speed of trust. I think that's really the base of everything. I think that when you have a trusting relationship with a patient, it is the foundation for how things move forward.
I'm Shaw Lou Taylor. I'm the Women's Health Nurse Practitioner for Community Healthcare Systems here in Georgia. Trust is one of those hard things to build as a provider.
You can't rush in and rush out. So I always start out with talking about how their day's gone, how their month is gone, how their family is. And then we can move on to, do they have questions? Do they have concerns?
So I think about building trust as building a bridge with a patient. And sometimes you're building a new bridge, but sometimes you're repairing bridges because they're coming in based on experiences that they've had that may not have been positive. You have to be able to recognize that quickly and figure out what is it going to take to help that patient to get that trust back. I have a lot of women who will come in and they're so amazed that we can refer them to a primary care provider, they can talk to a nutritionist, we can do smoking cessation counseling, lots of services or things that they would benefit from, but not otherwise have access to.
When you're taking care of patients, you need to have outside relationships with other organizations so that you can give good care. I have to have relationships with other OB-GYN doctors in other towns so that I can send them up there. We work with our shelters there in town. We work with our Pastoral Alliance there in town to also help, because they will help cover bills that might need to be paid for our patients.
We see things, we hear things, and then we can engage our community to help meet those individual needs. Every opportunity that we have to touch a patient is an opportunity to improve their quality of life. For my ladies, improve their maternal health for the lifespan, and then how that impacts everything else they do. And that to me is important, an opportunity, not just to take care of the problem, so to speak, but also the person.
Explore RHNTC's Preconception Health Toolkit and other resources at rhnTC.org. This has been a production of the RHNTC.
All right, so we are wrapping up, and I've got references here. And so my last question for you, and I kind of already know the answer because when you shared your stories, your challenges, and your successes, I know that you're working on practicing care, compassion, the right attitude, being resilient when things need to change, and most important, empathy. And the quote that I love that was read in the beginning is, when you look at the maternal health crisis that we're in, it really is very overwhelming. And so we really have to just work on it patient by patient. And just think about all the stories that were shared here today. Every single life that you impacted, that impact or that influence impacts that immediate baby, the other children, the partners, the family, the community, the workplace. That ripple effect goes very far, and there's really no end to how much you've made a difference. And so I want to leave you with the thought that what you are doing actually does make a difference. And finally, when a flower doesn't bloom, you fix the environment in which the flower grows, not the flower. And so as we think about this maternal health challenge that we have, and we are thinking about maternal health equity, everything that we do is changing the environment where our women are so that they can thrive. And as I mentioned before, when moms are well, they do their stuff really well. I'm the second of 4 children. I do not know how my mother took care of 4 kids and worked at the same time. I only have 2 and I'm struggling. I have a lot of gray hair now, which I've covered up with my special stuff that I can tell you about later. But really, we're doing good work. I do not want you to be dismayed or discouraged because the numbers don't yet reflect all the effort. But it's coming. And the more people that we can engage from our rural communities and our physicians that can work outside of the metro areas will make a difference. There's no reason that all of our counties should not have easy access to a provider. And that could be a family medicine physician, that could be a nurse practitioner, a midwife. There's so many things that we can offer. And so I just really want to thank you for the work that you're doing. And I want to encourage you to do more. And I want you to make sure you recharge so you can do more. And with that, I'm going to stop talking and just see if there are any parting comments. Do I have time to do that? Any burning comments? We did share a lot, so I don't want to encroach on the next speaker's time. But if you have anything that you want to share, And when I end my patient visits, I usually say, do you have any concerns or any confessions? Usually by the time I've softened people up, they just tell everything. So is there anything that would like to be shared? Everyone is quiet. Okay, so it's a great time. Oh, we have one comment. But once she's done talking, if you have an Apple Watch, you have to stand because I'm going to save you so you have your stand goal. So when she's done talking, just take a quick stretch break. Okay, we'll take your comment.
I was just gonna say, I love your approach and just how you keep it relatable with your patients. I think you have a really, I don't know, you just feel really warm. Even just sitting here in the audience, if I imagine myself as a client, I would feel really good. And the other thing, I was just wondering, are those peaches really that good looking in your town? Because if so, I want to go take a field trip and come and get some. Thank you.
Probably photoshopped a little bit, but. Any other comments, any confessions, any closing thoughts before we go? It's been an honor to speak with you today. Thank you so much. Please make a new friend before you leave today, okay?